Hello, and welcome to Breast Cancer Conversations, a podcast brought to you by survivingbreastcancer.org. I am Laura Carfang, breast cancer survivor and founder of survivingbreastcancer.org, a nonprofit organization providing community, education, and resources to empower those diagnosed with breast cancer and their caregivers from day one and beyond. Hello, my friends, and welcome to another episode of Breast Cancer Conversations. Thank you so much for joining us this week. If you are a longtime listener, welcome back. I am so glad you are here. If this is your first time joining us, welcome. Huge hugs going out to you. I'm so glad you found us. When you're diagnosed with breast cancer, we spend so much time preparing for doctor's appointments, making tough treatment decisions, understanding surgery options, chemotherapy, radiation, and navigating the waiting period between scans and waiting on results. One of the biggest challenges after a cancer diagnosis isn't just understanding your treatment. It's understanding the many different types of support that are available to you. Most of us know who's on our team, like our oncologist, our surgeon, a radiation oncologist. But what about palliative care? What about social workers, care coordinators, symptom management experts, behavioral health therapists, financial navigation? These resources can make a tremendous difference throughout a breast cancer diagnosis, yet many people don't learn about them until much later, if at all. Today's conversation is about helping you better understand the broader cancer care ecosystem and the professionals who work alongside your oncology team to support your physical, emotional, and practical well-being. I'm joined today with two incredible guests from Thyme Care. Dr. Julia Frydman is a palliative care physician and senior medical director at Thyme Care. A graduate of Harvard Medical School, she has dedicated her career to improving quality of life for people living with serious illness and expanding access to high-quality palliative care. She is joined by Dr. Stephanie Broussard, Director of Social Work at Thyme Care, and a nationally recognized oncology and palliative care social work leader. Stephanie has spent her career building innovative models of psychosocial care that ensure people living with cancer receive not only understanding medical care, but also compassionate, emotional, behavioral, and practical support. Together, we talk about whole person care, symptom management, palliative care, emotional well-being, and why some of the most meaningful moments in cancer care happen outside of the walls of a hospital.
We navigate the survivorship guilt and trying to reframe what their life looks like, because what life as they knew it doesn't really exist anymore. And so trying to grasp for how they reshape it. And that is a stressful task, and so it's really important that we have supports, because it can also feel like the rug was pulled from up under you because you've had somebody checking on you every day.
Welcome to the conversation.
Thanks, Laura. It's so good to be here. My name's Julia Frydman. I am a palliative care doctor and a medical director at Thyme Care. Here at Thyme Care, we focus on providing really whole person support to people living with cancer, including people living with breast cancer. And it's our mission through an interdisciplinary team, so including physicians, social workers, care advocates, and nurses, to make sure that people with cancer have all of the support they need in addition to what they're getting in their oncology clinics. So we are that extra layer of that support, that wraparound. And Stephanie is a close team member for me here at Thyme Care.
Amazing. Stephanie, nice to meet you. Thanks for being here today.
Thank you so much. Well, I'm Stephanie Broussard, and I'm the director of social work, and I lead our social supports. We have non-clinical and clinical social supports teams. And my background, as mentioned, is oncology and palliative care. And I also have a doctorate in social work as well. And so really passionate about leading this area of work for our teams. I believe that one of the things that makes us really unique is our approach to care and trying to make sure that people feel supported regardless of what their needs are. And I kind of think we serve the people in the gaps. Folks that maybe have challenges navigating their cancer centers or have wanted some additional information, or maybe just need someone to kind of help explain additional things. But maybe there's just something missing or could be added to their experience. I really believe that's who we're the most helpful for. And so excited to share today just about our experiences or any insights that we might can add.
Amazing. I love that. So this is like perfect and totally up our alley, because it's very similar to the work that we do. And our community definitely knows that survivingbreastcancer.org, we're here to provide the emotional health, financial support, emotional support, well-being, and whole person. I love that you use that term because we try and support that too. We are not medical oncologists. We do not try and be the medical team, but we really want to be an extension thereof. So it sounds like there's already a lot of amazing overlap for a great conversation today, which I appreciate. When you think about whole person support as you define that, what is like a typical day in the life for you guys? How do you get in touch with the patients and how do they leverage your services?
Well, I guess I'll go. So members can get to us in a various ways. Sometimes it is through us reaching out to them to try to explain our services and engage them in enrollment. Sometimes it is because there may be the contracted entity that we're working with, maybe their insurance or their primary care physician or even their medical oncologist has made a recommendation that they should connect with us as well. And so they have access to our information. And so that is normally how people find out about Thyme Care and how they engage. Be that we are reaching out to them to share our services, or they found out and now are reaching out to us for more information. And so that could look like a call just asking about, I've heard about Thyme Care. What does this even mean? Or what do you even do? But also when our enrollment team reaches out to people that may be eligible for our services, they do a really great job explaining who we are, what we do, and why there may be a value for people that are navigating cancer and where we could support them. And so everyone's needs are going to be different and the level of support may look different. And I think that's one of the unique things about our model is that we try to meet people where they are and provide the support that they need and try to, create unique care plans for each person that we're engaging with.
Absolutely.
Totally agree. And I think, the only thing that I would add is that when I think about supporting and engaging the members of Thyme Care, there are two parts to it. One is people are reaching out to us. They're having active needs. They know about them. They've identified those needs and they've identified that they need help, right? And they're calling us. And we are then meeting them where they are, just as Stephanie said. And then there's this other thing that we're doing, which I think is really important to the model, which is we're reaching out to them proactively and saying, hey, you didn't call us this week, but we're wondering how you doing. How are you feeling?
Yes.
How are your symptoms, right? And we have different, these are actually structured questionnaires that we're doing called electronic patient reported outcomes, and they're evidence-based. But at their core, what they are questions just like, you okay? How can we help you? Is there actually a symptom that you haven't reported to us, but that we could support you in? And that's that proactive element of the model so that people don't sit at home with an issue for too long, right? And they get support up front and sooner. And that's really core to sort of how we work.
Yeah. And I think just to add to that, Julia, one of the things that kind of struck out to me when you were talking is that also people don't know what they don't know. And exactly. So I think, with us reaching out and trying to share information or even check in, sometimes people don't know it's something they should be concerned about or they have a need that's going unmet because they may have a knowledge gap.
Totally agree. And
Completely.
In this breast cancer yeah, go ahead, Laura.
No, I was going to say totally agree, right? It's unless you've had a previous diagnosis of cancer or have cared for a loved one or have a family member with cancer, you really don't know what questions to ask, where to start. You're learning a new vocabulary. You are trying to navigate calendars and schedules and medications and symptoms. It is probably one of the most overwhelming things someone can go through.
And then even, focusing for a moment the population of people who are diagnosed with cancer, getting treated for cancer, living with breast cancer specifically, there is a wide spectrum of people, but there's also a lot of young people.
Unfortunately, right? Yes.
Right? And for those patients, they need to get care and treatment for their cancer, for their breast cancer, but their kid still has to get to school. Their kid still has to get picked up. They are still thinking about how to file their FMLA paperwork. So often in these younger populations, those proactive check-ins and the meeting people where they are and being hey, we will get you the support. We're not going to take a lot of your time doing it because we know that you have cancer and you still have all these other things going on in your life and you have so many things that you're juggling. So if it's text, we'll do it. If it's email, we'll do it. If it's a quick phone call after hours, we're there for you. So it's not just the kinds of interventions that we deliver that I think are really important. A huge part of the mission is also delivering them in a way that is going to work for people on their schedules, with whatever amount of time that they might have to get the support that they need.
Absolutely.
You just covered a bunch of topics right there. We started off with symptoms and tracking and, and then also life, I almost like life support in that sense, but life support in terms of day to day, right? Picking up the kids, groceries, eating, meals, life. And then insurance and navigating insurance and FMLA and how do you manage relationships and talk to your employer about all of this? Like it is heavy. So why don't we start with like the symptom piece? Because I feel like we all have like a bajillion symptoms that we are managing. And you're absolutely right. When, I think in our breast cancer world too, where it's predominantly women, although men, about 1% of men still get breast cancer as well. But I think we notice and kind of tend to like take on the world. We can do it. We don't want to say that we need help. Muscle through and fight through everything. So how do you help a patient understand when is something clinically significant where we should actually be telling you about our symptoms? Like when does, diarrhea, nausea, headache, numbness start to be a concern where it should be escalated up versus I hope this will just pass or I'll take some ibuprofen?
It's a great question. Maybe Stephanie, I'll speak to some of the physical symptoms and I'd love to pass to you around emotional symptoms because I think that's such a core piece here too.
Sounds good.
So around the physical symptoms, the way we function is we use these structured and validated questionnaires. They're developed by NCCN, so a National Cancer Guidelines Society. And we are either sending those questions by text message, or if someone doesn't want to do text message questionnaires with us, we're happy to pick up the phone and give them a call. Again, this idea that like whatever works. And depending on how our patients answer those structured questions, so they're structured questions around diarrhea or on shortness of breath, they will either get educational materials, if these are sort of what we consider like lower symptoms. They will always have an opportunity to talk to a nurse, but it is not required for those lower level symptoms, but we'll make sure that they get really good education about them. If there's anything that even is like borderline or a higher level symptom, a response to that questionnaire prompts a nurse to pick up the phone and call and then triage or evaluate all the symptom even further. And in that evaluation, make sure that the person walks away knowing I can manage this already with my over-the-counter medications. Or this diarrhea has gotten really bad. I'm getting dehydrated. I need to go get fluids. Or I actually need to go to urgent care or the ER today. So that's exactly kind of what the nursing team is doing, is providing that education and making sure people have anticipatory guidance about what to do with their physical symptoms, which I think is just like, I think it's hugely empowering for patients to just know, like, this is a problem. I'm not feeling well. I need to manage it, but like, I don't need to go to the hospital right now versus like, this is really serious and I need to get urgent attention. So a big part of what we do is education around that so that people can start to think through it and make good decisions there too.
As Julia mentioned, we have these really intentional tools that help us to be a little bit more proactive about screening and identifying when there's an issue or when there's a symptom change. But one of the things that I've found, especially from a behavioral health component, or even when we think about, the stress that comes with navigating social needs or the social determinants of health, is that oftentimes there is an assumption when people have cancer that there is a level of suffering that they're supposed to endure.
Right.
So that includes emotional suffering and sometimes even like just regular symptom burden, like the diarrhea you guys were talking about. They don't often know when the lever needs to be pushed to call their provider or call help, because we haven't had a lot of conversations about like what to expect when it comes to an emotional burden or what's normal processing and adjustment to diagnosis versus what's depression and what's anxiety. And so as a result, I feel like a lot of times when we're doing those first assessments with our members for and identifying their distress, oftentimes it's people first time coming to like the realization that like, wait, I'm carrying something. Like I am depressed or I am anxious, and this is not feeling anxious and appropriate adjustment. I may be navigating anxiety. And I think our team does a great job of bringing clarity to that, but also validating that it is also okay and part of the experience and not a part of suffering that you must endure. Yes, you must go through the experience. We can't hold it for you, but we can walk alongside you and normalize and help you develop skills so that you can cope and navigate through the circumstances. And so I think the biggest thing is really just making sure we normalize that some of this emotional processing is par for the course, but also what does it look like when it's no longer normal?
I want to take a quick moment and tell you something I'm really excited about. You can now download the survivingbreastcancer.org app directly from the App Store or Google Play. Just search for survivingbreastcancer.org. It is completely free to download, and inside you will have access to all of our support groups, educational programs and webinars, all of our blog content and articles, podcast episodes, and community features to connect with others who understand what you're going through. everything in one place because navigating breast cancer shouldn't require 15 open browser tabs. Download the app today. When you're newly diagnosed, you might be in this moment of like chaos and needing certain support services. Whereas if you're diagnosed early stage and finished active treatment, there might be more emotional healing that you need when you can kind of take your breath and realize, wow, I really went through something incredibly traumatic. And now I'm processing everything, because it's very different to go from weekly or even like daily radiation treatments to all of a sudden like, oh, come back in 3 months and we're going to do some scans to see how everything is. And so kind of that emotional roller coaster in terms of the intensity of treatment, I think, can also impact how people are processing.
Absolutely. That's anxiety. And sometimes even I've had members who like are navigating, like I'm trying to stop using navigating, but they're moving into survivorship, and they are almost survivorship. We navigate the survivorship guilt and trying to reframe what their life looks like, because what life as they knew it doesn't really exist anymore. And so trying to grasp for how they reshape it.
Absolutely.
And that is a stressful task, and so it's really important that we have supports, because it can also feel like the rug is pulled from up under you because you've had somebody checking on you every day, there's calling, and then all of a sudden there's nothing. And I think that's one of the beautiful things about, I hate to keep bringing it back to Thyme Care, but it really is, because I think we're what's missing, if I'm honest, like, and it's not to be a marketing ploy or anything, but like, I think we're what's missing because we are able to see you as early as we need to, but also we understand that there's the transitions and there's the level of support. Maybe when you're just diagnosed, you need more from us. We need to provide more education and support, but how we approach the support changes based on what you need. And I don't think a lot of spaces are curated and just don't have the resources to do it in that way. And so people miss out on that emotional support that can be really helpful navigating the transition.
Absolutely.
I think I would add one thing here, and you reminded me of something actually from my personal life. So, I mean, you started at the top, Laura. Like, no one's family isn't touched by breast cancer in some way, right?
Mm-hmm.
My mom is actually a 3-time cancer survivor and a 2-time breast cancer survivor. And my sister also was diagnosed with breast cancer at a young age. And she is 8 weeks away from finishing 2 years of Verzenio and, almost 3 years into treatment for breast cancer. She posts an album every week of her Verzenio pack. We have a family album where she posts that she finished it. And this week it was her 45th birthday. So she posted a picture like, I'm 45 and I'm 8 weeks out from finishing this Verzenio. And she's like, and she wrote in the caption that she feels untethered. Right.
Mm-hmm.
And again, it's this this thing you guys are talking about. Like, it's these transitions, and there have been many in her treatment and many in everybody's treatment. But she's like, actually, I thought I was going to be happy. I am happy. But there's this other thing going on where like this pack, this photo that I post, this been doing this routine stops. And then there's a lot of complexity that emerges there too. And it's really hard.
I think, Julia, one of the things that you're explaining is the ambivalence that we don't talk a lot about. There is the grief of experiencing cancer, but then also it is the gratitude of being on the other side. And there's everything about the gratitude. Very seldom do we talk about the grief or the transition and the emotions that come with that transition. We expect everyone to just operate from a place of clear gratitude. And there's space for both, but we don't always make space. And I think that increases the anxiety and stress that people have, because they're like, well, am I not, what's wrong with me that I'm not just grateful? Why am I sad? Like, who wants to be going to a cancer center? And those feelings are valid, but we don't talk about them.
Exactly. Your example, Juliet, I'm sorry to hear about your experience and all of the family members going through a cancer diagnosis. And, myself included and our community members, like, there's a countdown, 8 weeks left, 7 weeks left. Like, especially when a doctor tells you you're going to be on a drug for 2 years, 3 years, some aromatase inhibitors up until 5 to 10 years. Like, I don't even know what I'm doing tomorrow. How am I going to plan my life around these drugs, these appointments, whether it's a shot, infusion, oral pills that you are taking? It's really, it's disruptive. And, Stephanie, I think you too are hitting the nail on the head where, yes, it's not that we're not grateful, but how do we create space for both? Where, how do we have those conversations when we're back to work or we're done taking a pill or treatment and like, okay, great. I'm so glad to be off of this, but then what is protecting me and how do I know it's not coming back? How do I navigate the fear of recurrence or progression? And how do I like try and pretend to be happy when, everyone is like, oh my gosh, you're cancer free now. And I'm like, oh gosh, it's not a word I use. That's not a term I use. Where, some people are more comfortable saying no evidence of disease, or, you just don't want to like ring the bell, so to speak, so enthusiastically when there's still trauma that you're going through and processing.
I think even the symptom burden, I think I hear, I've supported people in survivorship. And one of the things I hear is that they have, maybe rung the bell. Some people may not even, who are navigating metastatic disease, won't even get to ring the bell, right? But that doesn't mean that the weight of the symptom burden doesn't still follow them. And so, yes, I may have no evidence of disease today, but I have neuropathy. And I have night sweats and I have horrible dental pain and all these things. And so how do you hold that? How do we make space for, and I even have people who don't like the word survivorship, and we have to make space for all the feelings and all the thoughts and, for people, because everybody's experience is different.
I wanted to ask Julia, you've been talking a lot about this model you guys have created, which is fantastic. And having like nurses available to respond to patient concerns or questions or escalation. Can you tell me a little bit more, like how does that work with that triage? And are these nurses part of like the Thyme Care team, or are you working directly with the like oncology team and like the home hospital, if you will?
Great question. So both. So Thyme Care has a fully employed nursing team. So we have nurses and social workers and care partners and nurse practitioners and physicians. And they are the ones who are answering the phone when people call. And in order to be effective in what we do, we're trying to close gaps, right? And to close gaps, you have to be closely coordinated with the primary treating oncologist, the PCP, any other relevant specialists. So anytime we are managing a symptom, managing an escalation, thinking through something with a patient, they've been in the hospital, we find out they got out, their provider might not even know. Like a core part of our work is care coordination. And we spend a lot of time like doing all the things. When we have integration into electronic medical records, like we're in the electronic medical record. When we don't have that, we're on the phone. When we don't have that, we're faxing, like everyone's talking about AI. I get it, but like we're still faxing and you still need to in medicine. I hope that's not always the case, but so we're doing all of those things. So yes, we have a nursing workforce and we are here for our patients and we are going to answer the phone and we're going to do it quickly. And the intention is not to cut them off from their providers. It is to augment the care that they're getting and make sure that everyone is always on the same page. So that's sort of the model in which we function.
You have this amazing clinical team that is supporting the patient. In care coordination. I would love to hear just a couple more like live examples. I think these like case examples are really helpful to kind of understand, yes, we're acknowledging all of the like multifaceted things that we have to navigate and go through. But in terms of, and I'm sorry, I don't know the answer to this, so I'm going to ask it, but like from the mental health perspective, do we have people who are helping from like psychologists? I know we talk a little bit about like social work too. So maybe Stephanie, you can take that one.
That's actually a great question. And so we do have mental health. So a lot of times when people think about who serves in the oncology or palliative setting, a lot of times, of course, we have our psycho-oncologists, which are our psychologists that practice in the oncology realm. For Thyme Care, we leverage our clinical social workers who are independent practitioners who specialize in oncology and behavioral health, or palliative care and behavioral health. And so that means that they are able to assess, diagnose, and treat symptoms, whether, related to depression, anxiety, mood disorders, all those things. And so what we have, similar to what Julia was explaining, our triage and escalation process is something, it's pretty crazy, but we have all of our interdisciplinary team is available for escalation. But we have different pathways because the needs are often different, but we're all operating within synergy. So say, for example, I'm going to call her Susie. Susie calls in, and today she's just having a regular call with the nurse. But while talking to Susie, Susie's in some emotional distress. And so while talking to her nurse, the nurse may ask a few questions, like maybe like a PHQ2 about like how is she feeling? Is she feeling sad? Has she felt like she's not maybe engaging in things that she normally would? And if yes, then she'll move on to ask additional questions like a PHQ9, which is just our normal depression assessment. Say Susie at that moment is needing more support, right? It's not enough to just assess, but she really needs somebody to talk to and process where she is today. We have the ability to escalate that to a clinical social worker who can provide emotional support at that time. And so we're processing real time. Is this adjustment to diagnosis? Is this exploration of mortality? Even when people talk about like suicidal ideations, those don't look the same when someone's navigating a serious illness. Sometimes it is just they're exploring their mortality and need someone to safely help walk them through that. But sometimes people are considering, and having thoughts about harming themselves. And so we need to be properly trained to support them in that way too. And so because we have the clinical social workers, we're able to navigate both. and provide that kind of support. But also sometimes it looks like maybe holding space for them until we could get them plugged into supports in their community so that we can get them plugged in. Maybe they need a psychiatrist, or maybe their MENA feels comfortable, prescribing antidepressants or anti-anxiety medications. And so we make those calls first to figure out what's the best path for them. And sometimes the treating provider just needs someone to help them navigate it. And so we're able to do that as well by sharing our assessment and our perception of where the member is. So we try to wrap those services around and then kind of tuck people in. So we do our initial assessment and then we bring them in and do a really comprehensive assessment. One of the things that we know, life doesn't stop because cancer is happening, but it can exacerbate all the things that were already there. So if the family is having dynamic issues or, you have interpersonal relationship issues before, cancer puts that thing, it's like lights it on fire. And so we are there to support all of those things. And so maybe the caregiver is burnt out and need somebody to just talk through the burden and validate their concerns, but also get them to some support themselves. We do that too, because we know that we can't support the member without supporting those who care for them. But we want to make sure that people have access to the right support at the right time is really our goal. And so if the support is a provider, then they get a nurse practitioner. The nurse practitioners can help support that with our ESC or our urgent care visit. Or if the support is a clinical social worker to process that, it's a clinical social worker. Or if it's a nurse to just kind of walk through some education and symptom management, it's a nurse. And so I love that we're able to do all those things. But we also don't forget those, I feel like I've said so many words, I'm sorry, but we also don't forget those social needs, because being poor is stressful, or feeling financial toxicity is stressful. So we don't say, oh, just talk to us about your feelings and good luck with figuring out your light bill. We say also, how can we help you with those practical needs that are a burden and you're trying to also navigate? How can we support you walking through those things? We may not always have the resource. We may have to try to figure out what's going on in the community. And there's some communities that are depleted, so we may not even find an answer, but we can support you with figuring out how do we navigate in spite of those circumstances.
So in those examples, and thank you for that thorough overview as well. So in those examples, are you connecting them with financial wraparound services in their communities or applications for them to apply for financial assistance? Or do you guys actually offer that as part of your arm and your whole person approach?
So we don't personally have financial assistance ourselves. So we're connecting them to whatever is available. So it could be a grant application. It could be a benefits application. It can be a community-based program that we've identified for them, because we want to do the legwork for some people. There's some people that if you give them the phone number and email, they'll figure it out and they can carry it. There are some folks that the weight is so heavy that they need you to help them make the calls and figure out what's there, or even sometimes support them while they're calling their insurance and trying to figure out the answers. And so we do whatever, and I hate to keep saying it, but we really do meet people where they are, and whatever the level is that they need, we try to give them that.
I need one of you guys. I need help. That sounds amazing. So, I guess the elephant in the room is because you talked a little bit about the membership and working with care teams, and it sounds like you guys are mainly virtual and helping across state lines, or maybe tell me a little bit more about because I get really confused and overwhelmed in my own experience of how do I get access? Is it covered by my insurance? Who's actually paying these bills? And, I know sometimes when I travel and, visit family in other states, I can't do telehealth because my practitioners aren't licensed in those states, et cetera. So it's very complicated. So how do you help, not me, not just me, but how do you help patients in these situations where it's not necessarily I'm in Boston, I'm in Massachusetts, it's just out of the box right here?
It's a great question. It goes back to sort of what Stephanie sort of talked about at the beginning, which is who can access Thyme Care today? Would it be okay if I started there, Laura?
Sure.
I think it might be helpful. Okay. So there's a couple different ways that you can access Thyme Care services today. We currently don't have, what is called a direct to consumer offering. So you can't just go online today and sign up for Thyme Care.
Okay, so my listeners are going to be oh my gosh, okay, when is that coming? No, but good to know.
But I want to, but it's important to know that, right?
And it's important to say today, Julia.
Today, absolutely. I would, and we are partnered with a lot of different organizations through which patients can get Thyme Care for free. Those organizations are a lot of different insurance companies. So large insurance companies across many states. We are partnered with multiple primary care groups, and we are partnered with multiple very large employers. So that being said, for your listeners, please still go on our website and see if you're eligible, because you can't get it yourself if you're not affiliated with one of these organizations. And we are affiliated with so many organizations, and it's changing all the time, that it's worth taking a look.
Okay.
If you are affiliated with one of these organizations, whether it's a primary care practice or an insurance company that we have a partnership with, we're free. and we will cover you in any state. So we are 50 state licensed across our nursing, nurse practitioner, and physician team, and our social work teams. That's the model. And so, when your doctor says like, you ran out of gabapentin, but you're in California and I haven't seen you in 6 months, it's a perfect use case for Thyme Care. Like, we'll see you for urgent care. If you're a member, we will prescribe you a short supply of gabapentin. We will talk to your provider. We will tell them that we did that and that we can do that because we have licensed providers in California. You will go home. You will get your normal refill. So that's sort of like at a very high level how we work and how we work across the country.
Wonderful. So like really that triage support system.
And I think in addition to, I think our triage is one of the most a very valuable part of what we do. But I also think like the day-to-day support that for our people who are kind of maybe, they're not in crisis, they're just going through life, living with cancer. Those are folks that we touch too. And so that means we're doing those check-ins. It's just, hey, just wanted to check in, see how things are going. Or that text, hey, I hadn't talked to you this week. Like, how does that, how are you doing depending on the cadence and what people are comfortable with? Because we only reach out to them based on we kind of ask those kind of questions. How often do you want to reach out? If things change, we pick up the pace or we slow down a little bit if they need that too. And so, yes, we do a beautiful job of triaging, but we also do a wonderful job of just walking alongside folks and being that safety net if they need us.
Yeah. Yes. You're just reminding me, Stephanie, it was actually a patient with breast cancer that one of our nurses was telling me about recently who wasn't in a moment of crisis. It was a normal check-in, as normal as a check-in can be for someone who's living with cancer, right? But she was doing okay. No new imaging, was going along on her treatment. They had a long conversation. And at the end of it, the patient said, just thank you for talking to me and just allowing me this space, be upset and not pretend that everything's okay, right? Nothing in particular is going on today. And, my family, my friends, I always feel like I have to put on this brave face for them. And you just gave me a moment to not do that. So again, to Stephanie's point of just walking alongside, that's what was accomplished in that visit, right?
Yeah.
And it was really impactful for the person.
Yeah. Sometimes it's amazing not to say that we're underestimating ourselves, but we don't actually realize sometimes the impact that we have on the people that we're serving until you hear these testimonials or these thank yous or these moments of wow, I really needed that today. Thank you for being here for me.
I think we have a kudos channel that we kind of drop, when beautiful things happen or someone shares a thank you, a member sends us a thank you so that the whole team can fill in and see it. Because the work is hard and it's important. So it's important for us to also feel the wins, even if we're not the one getting to hold it. And the most inspiring thing to me has been the fact that the things that people appreciate most, now they're extremely grateful when we do the big things. Find them a grant to cover something that they couldn't, everybody said, we had a member that was $120,000 in debt and we were able to help navigate all of that to address that burden because it was actually a mistake on somebody's side. And we're able to help circle it all through and do great navigation. Of course, people are grateful for that. But the things that I see most are just the small moments where they feel seen, heard, and cared for in a way they had not before. I talked to my doctor about this a million times. This is the first time I've ever been clear, or, it felt this way, or like Julia was explaining, thank you for giving me the space, or now I understand things better. It's the really small things that I feel like people value the most because I think those are the things that other people sometimes disregard as a need. Where we have the space to kind of honor those things.
Yeah. Yeah, I think, we're sort of talking about part of it is bearing witness too. And it's really important. And it's just reminding me, and we haven't focused a lot on this today in the conversation. I think it's worth talking also about people living with metastatic and life-limiting breast cancer. And this is the minority of patients, thank goodness, today. And also, thank goodness, life expectancy for those navigating metastatic breast cancer continues to increase all the time. That being said, there's so much that needs to be done to support this patient population too. In the bearing witness could not be more important, right? They go to the oncologist. The oncologist says, you're doing good. You're still no evidence of disease. It's working. Life expectancy looks good. There's a new therapy coming. And these are all amazing things. And folks are living with a really difficult reality and need the space to process what that means. And how are you a human living with this and knowing this and living with that like elevated degree of uncertainty. Like anytime someone's diagnosed, things become uncertain indefinitely. And this is like an elevated degree of uncertainty. I would be remiss as a palliative care doctor not to tell you to look for outpatient palliative care in your clinic. I think there is this really common misconception that palliative care is somehow means that your prognosis has changed or is worsened or it's synonymous with hospice. Those things are not true.
I think there is a misconception around perceptions of palliative care and when to use it. And there are so many benefits from being able to engage in palliative care, but oftentimes people get upset even if their provider brings it up because like, what does this mean? Like, are you giving up on me or is this about hospice? And it's not. It's really about adding things rather than take things away. And so palliative care can be extremely helpful with exploring all of your burden. It is literally designed to be whole person care where it takes into account your emotional suffering, an emotional burden, your physical suffering and your physical burden, your spiritual needs as well, and even the family and how to support them. And so palliative care can be absolutely impactful and oftentimes it's dismissed by a lot of folks when there's real true benefit that it can provide at any stage, at any age and any stage of disease or diagnosis, but especially those navigating metastatic disease.
Yeah. We share that a lot too. So thank you for like kind of hitting that home as well. Like palliative care is not hospice care. And people have access to it. Talk to your doctors, talk to your team to say, okay, what resources do I have here in the clinic, in the hospital? How do I get hooked up with my palliative care doctor?
Even if a person isn't receiving palliative care specifically, how do we make sure we approach their whole person care with taking into account all of their symptom burdens and making sure those needs are met? And so I think it's a lens in which we see the world. Once you're a palliative care, once you're in palliative, you've had the Kool-Aid and, it changes how I see the world just in general.
Absolutely. Well, I think just doing this work, right? You were talking about just how the weight of everything that we're carrying is heavy, even for us, kind of even on the administrative side, right? Where when I started survivingbreastcancer.org, I was so excited to launch the organization. And I don't know why I didn't put two and two together, but like the first couple of times I'm like, oh, I got my email address. People are finding me. But every email is, I just got diagnosed. What do I do? Every single email was like, right? I mean, obviously that's what they're looking for. But to me, I was like, oh my gosh, someone else just got diagnosed with breast cancer. Someone else just got diagnosed with breast cancer. You're just like, this is my world. So having that like kudo line of like, our work is really important and we're all together helping and supporting the people that we care so deeply for is beautiful. And, you got to celebrate those wins and that support and honoring what those people's values are, how they would like to be treated, respected, the language that they use. You guys are hitting on all of the right things. And I hope we get to work with you guys because, I think, as you're looking and navigating that triage, I hope you consider also survivingbreastcancer.org as an extension of those resources. And since all of our programs are virtual, online, 100% free to the community and extend across state and country lines. So there's a lot of synergies right there.
Absolutely.
What have you been noticing in terms of outcomes?
One of the things that even when I joined Thyme Care, we knew that there was a component and an element and a need for behavioral health support. I think we knew people were having trouble with, the emotional distress as a result of our, distress thermometers and EPROs that we were doing already. We knew that people were having some need. I think one of the things that we did not expect was once we started asking and expanding the more intentional questions around the emotional distress, how many people would be carrying and holding such severe emotional distress. And so one of the things I'm extremely proud of my social work team, we have grown really, really quickly, but not only are we assessing people proactively, but also reassessing as their needs change, but also we're helping avoid crisis. And I think that is not an easy feat to do remotely with a large population. And it means that we're able to identify a large portion of distress that has gone missed because a lot of places don't have the ability to properly screen. Some places, of course, do NCCN, but maybe don't have the infrastructure to go to a PHQ-9 or are afraid to because what if they say they're suicidal? We don't have the resources to send them anywhere. So why open the door? And as a result, if the question isn't asked, it doesn't mean people aren't experiencing it. It just means we don't know. And so asking the questions, and I made a decision not only to ask, but to provide the support and make sure people get to the right level of care. We've seen a drastic increase in not only the amount of distress that people are severe distress or even folks that may have been in a BH crisis, but also folks that would have ultimately had to be seen in an emergency department for a BH admission due to being actively suicidal or having, intent or a plan, we're able to get in front of that because we're proactively assessing. But even if they are in that place, we're getting them to the right level of care at the right time. So maybe that looks like intensive outpatient. Maybe they don't need to be inpatient. Maybe they need to be plugged into a provider who can monitor them, and we monitor them together so they don't miss treatment as a result of being inpatient. And I think that is something that we didn't expect to be an outcome, but I'm really proud of that. Now that we have it, we're able to provide that support.
Yeah. Beautiful. I mean, what your team does is incredible. And, I would add, just like on the broader program, something that I'm really proud of and that's really important to me is that our member satisfaction scores are always like through the roof, right? So people are really satisfied. And that is an outcome in and of itself is something that is like prized for me, right? Every day, wake up, do the work. Are the members getting what they need? And like the resounding answer has been yes. Other outcomes that we've been tracking and now on sort of like national population level data sets we're able to say are, do your symptoms improve when you engage in our programs? Yes, they do. Right? Your diarrhea improves. Your nausea improves. We help you with these symptoms. Are we able to prevent you from going to the hospital for something that does not require a hospitalization, like you just need some fluids or you need to take your Imodium? Yes, we now have shown definitively that we can do that with our interdisciplinary team. If you do need to go to the hospital, when you go home, are we able to prevent you from having a readmission, right? Because when you go home, that's still a really risky time. Like, did the discharge folks give you all the right paperwork? Did the pharmacy have your medications? Can your primary care doctor see you? There's a lot that goes on. And we now have definitive data to show that we prevent you from going back to the hospital when you don't need to go, right? And no one wants to be in an ED or be in a hospital when they don't need to be. If you need to be there, we will get you there. And we will, like we talked about at the top, get you the advice and get you there quickly and connect you to your team. And if you don't need you to be there, our goal is to keep you in. And then just the last thing I'll say is we have a virtual palliative care program where we actually see patients for palliative care. And the other outcome that I wanted to just talk about was that we are improving access to palliative care around the country. So we have a goal of plugging patients into existing palliative care infrastructure, if it exists, because we always think you can be really well served in your oncology practice, in your health system, in your home, in your community. And in some places that is not possible. That does not exist. So just another outcome is that we are seeing an increasing, really significant growth in our virtual palliative care program. And it is improving access in areas where there are not clinicians for people living with serious illness. So those are just some of the things I'd call out.
I really appreciate this dialogue, this conversation, the incredible work that you're doing, and you enlightening us and our listeners about the resources and, for people to be able to check with their employers or their insurance companies and their hospitals to see if they have access at this time, and to continue to provide access and fill these gaps that we know are happening. And unfortunately, in a situation where we know hospitals are closing, people are losing access to resources, that this is becoming such a critical need. And so I really appreciate the work that you guys are doing. Thanks for being here today.
Thank you so much, Laura.
And thank you, everyone, for listening to our show. I would like to acknowledge that all of the information on our podcast is from personal experiences and is not a substitute for professional medical advice. You should always contact your medical care team. If you are looking for specific topics or would like to be a guest on our show, please feel free to reach out. My email is laura@survivingbreastcancer.org. Our show is made possible by our nonprofit, survivingbreastcancer.org, and by our incredible donors like yourself. You can hop on over to survivingbreastcancer.org to sign up for our mailing list, make a donation, and explore the 400+ programs we offer each year at survivingbreastcancer.org/events. Until next time, keep on thriving.